morning and welcome to the first meeting of the municipal year of the Adult Health and Social Care Policy Committee, or at least the first proper meeting not in the AGM. My name is Councillor Argenzio and I am the chair of this committee. The meeting today is open to the public. There are no items that contain exempt information. The meeting will be webcast and the recording will also be available for people to view later through the Council's website. It is also possible that Sheffield Live TV will record and rebroadcast this meeting. Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test for today. If there is an emergency evacuation, please take instructions from the Town Hall staff, and the assembly point is Tudor Square. I will now ask each committee member in turn to introduce themselves and then I'll go on to officers. And actually, before I do that, can I say welcome to Matt Boucher, who's our Interim Executive Director of Adult Care and Wellbeing.
Good morning, I'm Laura McLean, I'm Councillor for Walkley and also Group Spokesperson for this committee. Thank you.
Morning, I'm Councillor Ruth Milson, I'm the Councillor in Crooks and Crossbow Ward.
Good morning, I'm Councillor Mick Rooney, I represent Woodhouse Ward.
Good morning, I'm Councillor Christine Gilligan and I represent Hildborough Ward.
Good morning, I'm Councillor Steve Ayres and I am Councillor for Graves Park Ward.
Morning, Councillor Sophie Crossthorne for Beechif and Greenhill Ward and Deputy Chair of this Policy Committee.
And welcome to Councillor Dunn and Councillor Kubo, who joined us on the committee this year. Can I ask officers to introduce themselves, please?
Preston. Wow, looks like it's about to take off. Morning, everybody. Matt Boucher, the Interim Director for Adult Social Care and Wellbeing.
Morning, everybody. Sherry Grant, Assistant Director for Legal.
Morning, everybody. I'm Rachel Marshall, Principal Democratic Services Officer.
And we also have Rebecca doing all the tech stuff, so thank you, Rebecca. So the first item on the agenda is apologies for absence, and I received apologies from Councillor William Sapwell, who unfortunately can't make the meeting this morning. Item 2, exclusion of press and public. As I said at the beginning, there are no items on the agenda that mean that we need to do anything in private, so we're good to go. And item 3 is declarations of interest. Can I ask any members if they have anything that they want to declare for any items on the agenda, any interest? Okay, I just want to mention, Sherry, I noticed when I was going through the papers later, then in item it's the one that Sherry's, Kelly's doing. The item 11, in one of the report attached, there's quite a few mentions of City of Sanctuary in the pictures and the Spring Project, and I work for City of Sanctuary, so they're not named as such, but there's quite a lot of graphics about that. I just wanted to say that I work for City of Sanctuary, but there's nothing in the report that really
that affects their
I just want to so I just wanted to mention that.
Do you want me just to clarify that, Councillor, that's okay as long as there's no financial, which there isn't from what I've read of the report.
Thanks. And then we have minutes of the previous meetings. So they start on page 11 of the pack. I'm going to go through each page, and then we can look at matters arising and accept them all at once, and I'll sign them. So on page 11, page 12, 13, 14. Just in terms of matters arising in 852, let P, I just wanted to make sure that there is a note that a 6-monthly briefing on work on Sheffield Adult Safeguarding Partnership Board will be provided to members, just to make sure that that goes in the work programme at some point, either in the DAS report or a separate report if it needs to be a separate report. Just as a reminder, I don't know if it's on the, I couldn't see it on the work plan. Page 15. Page 16. And in item 86.4D, the letter was sent finally on the 3rd of June. So I was copied into the actual email, so I know that that's gone out. Page 17. Okay. And page 18. And page 19. 20. And 21. So those were the minutes from last proper meeting, if you want, where we were here, just us. And then on page 23, there are the minutes from the AGM that we had. So our first meeting, which was the 19th of March, 19th of May, which is when we had the AGM with the full council. So can you look at those? It's on page 23 and a tiny bit of page 24. So are people happy that those are an accurate record of the meetings and there's no matter arising? Brilliant, thank you. I can sign those then. Brilliant. And we have item 5. Which is appointment of substitute members to Health Scrutiny Sub-Committee. I'm going to read what's on the agenda, but there are some errors, so Councillor Crosthorne is going to just give us some clarity. To note that the appointment by the monitoring officer in consultation with the relevant political group whips of Councillors Sue Alston, Penny Baker and Cliff Woodcraft as substitute members for the Health Scrutiny Sub-Committee with effect from the 4th of June 2025. Councillor Crosthorne.
Thank you, Chair. Apologies. To clarify, the full members appointed to Health Scrutiny Sub-Committee from the Liberal Democrat Group are myself, Councillor Sophie Crosthorne, Councillor Steve Aris and Councillor Penny Baker. The substitute members to approve today are Councillor Anne Whittaker, Alan Woodcock and Will Sackwell.
Thank you, Councillor. I will actually liaise with Democratic Services because there should be the green substitutes there as well, and I'm not sure why they're not included. And because there is a date, I will do that after the meeting, is fine. Item 6 is public petition questions and statements. We received no public petition questions and statements, so I will go on to item 7, which is members' questions. We did receive a question from Councillor Crosthorne. The question with the answer was published this morning on the website and will be published with the minutes from this meeting. Councillor Crosthorne, do you have any supplementary questions?
No supplementary questions at this time, Chair. Thank you.
Thank you. So we're going to move on to item 8, which is the work programme. This is on page 27 of the printed pack, and Rachel is going to guide us through that. Thank you.
Thank you, Chair. If you leave to page 27 of the agenda pack, that is where the work programme is laid out. Obviously, this is a new work programme for this municipal year, and we'll be asking you to agree the recommendations which are set out on page 28. From page, scrolling down, from page 33, you will see all the meetings for the forthcoming year, and it sets out all of the agenda items. I'd like to point out that this is a fluid document and it is subject to changes and edits, but this is as it stands now, and following the work programming event day that we had, this is what has been agreed to date. I will just actually note, Chair, that you have just mentioned as a result of matters arising from the minutes that you want something added into the work programme, or we need to check that for what Chair has just mentioned there. So we can certainly, I can actually probably pass to you, Matt, on that if you had any comments on that, but certainly if it's open for everybody else to discuss, and if anybody has got any comments on things that need to be added or edited, please feel free. I will pass back to you, Chair, now, and if Matt does want to come in at any point regarding what he said in the minutes, that's absolutely fine.
Just in terms of, we had a cross-party meeting regarding the work programme. Was it last week? So we kind of had a look at it, and what we've been trying to do is to slimline it, because you know, in the last 3 years we've had some really kind of substantial agendas, so we're trying to rationalise it and make it more manageable. So most of the updates will be part of the DAS report, unless we need a specific report to come back to us, because it's, you know, we need to comply with something, so we need to see something every year. But as Rachel said, the work programme is always a draft, because things change. Sometimes we need to move things, and you will notice that the CQC update is there 3 times because we don't know when they're coming. So obviously, whatever comes out of the inspection will be discussed at an appropriate time after that happens. But yeah, if people you know, have any suggestions of anything that, or we can discuss it in briefings and then put it on the agenda if it needs be. In terms of the 6 monthly update, that is something that was agreed and minuted in a meeting. So because we've decided that that was a recommendation, we do need to have that in, you know, so I think it's October sometime, but can be, from my point of view, it can be part of the DAS report. Matt, do you want to say anything else?
Right, sorry, I will get used to this microphone system in the end. Yes, so we've got the safeguarding report, the annual report on the agenda for the back end of the financial year. I think, given the breadth of the agenda, if we slot a safeguarding performance update into the September meeting, that would probably meet the recommendation. And just to add, the steer that members gave was very clear. You don't want 500 pages worth of reports. You want to focus on the chunky stuff, the 4 decision stuff, and the risky stuff. So thank you all for your contributions. That's what we've tried to do in building the programme, get the stuff in there. And I think on the agenda today, there's plenty of time to get into the right level of depth on the topics that you've got in front of you. Thank you, Chair.
Thank you. Laura.
Thank you. I just wanted to comment on the safeguarding update for the 6 monthly cycle. I think from memory it was that it has been 6 monthly, but we'd agreed the formal update would be 12 months, but we'd have like an informal update, not necessarily in the committee meeting, or maybe in the DAS report, sort of at a midpoint from memory. And just to say thanks to all the officers for the work on the work programme over the last couple of months, because it's been, turned around really quickly, so we do really appreciate that. Thank you.
Great, thank you. So the recommendations are on page 28, that the usual with work programme, that the committee work programme as set out in Appendix 1 be agreed, including any addition and amendments identified in paragraph 4 of the report, and any agreed by members at the meeting. That any referrals from council and committees, petition and resolutions detailed in paragraph 2 of the report be noted and proposed response set out as agreed. Okay, are people happy with approving the work programme as it is for now? Brilliant, thank you. And we're moving on to item 9, which is the adult mental health update, including mental health social work provision update. And I believe that we have 3 people presenting. So we've got Tim, and Tanya, and Sid. Could you introduce yourselves when you sit down? Thank you.
Morning. Morning, everybody. My name's Tim Gollins. I'm the Assistant Director for Mental Health Access and Wellbeing. I've got a couple of colleagues with me, Tanya Bowden, who's a Service Manager for Community Mental Health Teams, and Sid Fletcher, who's the AMP Service Manager. They'll be in the right place to answer many of your questions. So I'll give a summary of the 2 reports, and then hopefully we'll get into discussion. Is that okay? Okay, so the 2 reports cover the community mental health services and the AMP services, and it highlights some of the key pressures across both of those areas and some of the service responses to them. The key issues for the community mental health teams are, there's 5 of them: performance, recruitment and retention, hospital discharges, demand and acuity, and I'll briefly go through each of those. And in the AMP service, there's maintaining the AMP rota, demand pressures and succession planning. There are no climate change or financial or legal implications of either of the reports. They're for noting. The background to mental health nationally is interesting. The significant demand pressures. There's been a number of reports nationally that highlight that there's 23% increase in young people coming through to adult services with increased mental health problems, increased incidence, that is. And between 33 and 45% of secondary care services receiving increased numbers of people with mental health problems too. A recent ADAS, which is the Association of Directors of Adult Social Services, showed that 81% of all DASs are recording increased demand for their mental health services. So there's 152 local authorities. So some of those generalised increases in demand for mental health services are driven by the national socio-economic factors such as post-COVID sort of legacy, debt, cost of living, homelessness, poverty, unemployment, social media indeed, and generalised inequality. It's quite a complex picture. So just focusing on community mental health social work teams, they are of course co-located at Eastglade and Northlands. They're doing really well in terms of attendance, on less than 5% sickness levels, and they're working really hard. They're actually in a very challenging context, managing to bring down a number of safeguarding tasks and a number of duty tasks at the same time. And we're currently in a major round of recruitment. So we're recruiting for 18 posts at the moment. There's 6 social work posts and then a maximising independent service. And we've had a really good response to that recruitment round. We've had 366 applicants for 18 posts. So that's 20 applicants per post. So we haven't had that kind of success for quite some time. There are challenges. So in terms of performance, there are 186 people waiting for social worker to be allocated, and we're only meeting 27% of annual reviews that are due. Caseloads are high, 15 to 20 per staff member, and we've got temporary funding for hospital discharges, which means we're using quite a lot of agency staff in that area. Demand is increasing. There's various measures of demand. Daily tasks up 50% over recent months, and there's 13% increase in open cases between December 24 and May 25. So we've got that context of increasing demand. But also there's increasing acuity. So it's not just that we're getting more work through. It's difficult to measure acuity, but using a proxy measure of deprivations of liberty, the numbers of them, it suggests there's a 20% increase in complexity that we're dealing with. In terms of the kinds of things we're doing, we're obviously doing a big recruitment process at the moment. We're developing a hospital discharge hub, which brings us closer to Sheffield Health and Social Care Trust on the discharge wards. We've got a training and development programme, particularly for the new staff that will be starting. We've got a big focus through the Maximising Independence team on independence and autonomy to make people sort of independent in the community as much as we can and avoid more expensive high intervention services. and we're reviewing our systems and procedures to make sure we're as lean as we can be. In the longer term, we've got an eye on artificial intelligence and how we might be able to use that in line with the corporate priorities. And we've got a waiting well programme so that we are keeping people waiting safely. In terms of turning to the AMP report, we've got a centralised AMP team and supported by two groups of staff. The first is community AMPs and also bank staff. We've got a growth pressure of about 10%, which is equal to 2 AMPs, as those approved mental health professionals. And we've got an ageing workforce, actually, so we're doing some succession planning. The kinds of things that are driving up demand for the AMP service are out-of-area assessments. So that's where we're having to travel further to do assessments out of area. Demand increasing from the police for and the use of the 136 powers. That's where they detain people in public areas. Their introduction of Right Care, Right Place has slowed processes down, which has increased demand for us. A&E referrals are higher, and also referrals from other Sheffield Teaching Hospital sites are on the increase. So we are succession planning. We're expanding the bank staff that's available to cover the 24-hour rota. We're introducing increased community AMPs to support the AMP rota too. Again, we've got an eye on artificial intelligence in the future, and we're charging for out-of-area assessments. So there's a number of things that we're doing in those spaces. Obviously, the background to this is that we deliver both community social work teams and the AMP service in partnership with our health partners, particularly the ICB and Sheffield Health and Social Care. And so with that, I'll end my summary and hopefully open you to questions.
Thank you. Are Tanya and Sid going to come into the answers? I just wanted to, just for people who might be listening, I just want to say that AMP means approved mental health practitioner or professional, because, and it's spelled with an H, so it's AMHP, because we say AMP, but yeah, just in case people don't know out there what it means. I've had Councillor Dunn.
Yeah, thank you. 2.3.3, you said 23% increase in young people. Is that correct? I did hear that correctly, didn't I? And it said that you're going to be maximising the independence team, which is good. Do we have data on whereabouts these young people are? Are they spread across the whole city, or is it in certain areas of the city? How are we linking on the ground with our local area committees, with our councillors, so we can really tailor that? Because to me, a lot of it will do without access to a lot of independence, access to fun. As we know, there's a lot of issues to do with accessing that. So I'd like to know more about that and how we can steer that rather than just dealing with the issue, you know, of the mental health. Thank you.
So it's a brand new team. We're recruiting now for the team. Some of that I'll have to talk to people about and find more information. What I will say is a lot of the young people coming to me are actually not even in Sheffield. That we've had our resources have been quite slim in Sheffield, our options, and I am finding people are coming in from out of area. So I don't know if you have any particular area data, Tim. I can't say. In all honesty, I don't have an answer to where particularly they're coming from, but I'm certainly mindful of what you're saying and took into that.
So you could get the data, because I think with him saying it's coming out, but they still will be living somewhere that puts an issue on. To me, they're a young person. Do you know whether they come from out here because they need to be safe? That is absolutely understandable, but they become part of our community, part of our city. So we need to be able to know that, reflect that. Thank you.
So the young people that are coming through to adulthood come through children's services. So they're across the city. It's not all the young people that need adult social care services, so a lot of young people are going through the SEND process and education training route and perhaps into employment. but the people we work with, we're certainly able to locate them geographically. We can do that piece of work if you would like us to.
I have Councillor Aries.
Thank you, Chair. My recollection is that we've had quite... I'm sorry, I'm referring to paragraph 2.3, and particularly about recruitment and retention, which is a bit of a pet subject of mine. It's been over time. And my recollection is that we've had a number of invest to save programmes, and I'm just wondering, particularly with reference to the, getting on top of the backlog, what the impact, can you just enlighten us, Tim, on what the impact of those invest to save programmes have been with regard to that particular area?
Yes, so the background to this is that the social workers came back from Sheffield Health and Social Care Trust in April 2023, and they came back with, if you like, a significant backlog of work, about 700 outstanding allocations. And you're right, we got some investment to bring down that backlog. That was successful. It brought it down to about, I think, to my mind, I think it's about 180. So we reduced it significantly with that investment, but it didn't get rid of it entirely. And we've been working through the remainder of that backlog since that time. So it had a major impact, that investment, on our backlogs, yes.
But that particular funding, that is now...
Yes, that was agency funding, which ended, I think we had 6 months worth of agency funding to do that work.
Thank you. I'm going to take Councillor Milsom and Councillor Rooney and then get other people. Thank you.
Thank you, Chair. Hi. I've got a question around the maximising independence team, which it suggests is on track to become fully operational. I think it says in the report. And just thinking about what kind of monitoring and evaluation around that work can be conducted once that is fully operational, and how would feedback be encouraged in that and involving all the right people in that feedback loop. And then I've got just a bit of a concern really about the right care, right place, and we look at general trajectories and general paths for improvement, but then you still hear individual cases where things haven't gone quite right. And I just want to sort of put a hypothetical case together, which is kind of based on some real life things. So in a hypothetical case, someone is admitted to hospital in mental health crisis, and then the discharge pathway doesn't help to enable them back into an independent life. For example, in Sheffield, you might expect a pathway that goes to step down and then back home to a relatively independent lifestyle. But if the patient were to be put onto a general ward for whatever reason, and I'm not sure what that reason would be if they've gone in a mental health crisis, then the rules say that they can't go to step down from a general ward. And so then they're stuck in a place where they can't be discharged to the right care in the right place. And that obviously has a detrimental effect on the patient's recovery. And also the recourse to a personal budget, which would allow somebody to purchase PA support in a way that's structured for their own thriving independent life. But if they thrive too much, then perhaps they get assessed that they don't need all that support, and then they'll go round a loop of not thriving, going into crisis, coming back, full support, and then it goes round and round. So how can somebody who needs that level of support be guaranteed that that's sustainable for their longer term, and that they don't keep going round a loop?
I'll take Councillor Rooney as well, and then you can answer all of them. Is that okay?
Okay, thank you very much. Could I just say how surprised and disappointed I am in the answer that you gave to Councillor Dunn's question about do we keep a track of where the most... because I would have thought that was glaringly obvious that we ought to be doing that so that we could concentrate whatever resource, the limited resources that we've got into the right places. I am extremely disappointed by that answer.
Okay, so perhaps Tanya could take the maximising independence team question, and Sid might be able to talk about right care, right place, and I'll come back on the young people. Tanya?
The maximising independent question, just to remind myself, you were talking about how are we monitoring, how we're doing. Fortunately for me, this is a brand new team, so I've already set up a system with our business support and with IT to monitor from the start. We have some really clear KPIs for what we're trying to achieve. I'm interviewing for the team manager at the end of next week, and I've got some staff already on board. So what I will say as well is there is some model we're following. We've been working with a project called the Promoting Independence Project in the private sector that's coming to an end. So we're also working closely with them, so we pick up on their very successful model. So we're using that as some part of our base for what we're doing. But yes, I also have it's hard to explain, but I also have a way now of recording what we're doing, and actually at base it's sort of keeping on an ongoing record spreadsheet of what's coming in, starting with something like where the person starts at. But there's two things I need to measure. I need to measure obviously there's a financial aspect of it, to be sure, but there's also the person's success, the person's report. So I'm measuring two sides of things, both the quantitative outcome of the team, but also, for me, it's very important as well. We have someone we're working with who looks at the qualitative side of things for people. So the idea is that we will effectively move people from more restrictive to least restrictive options. And yes, we do have some systems in place to measure that. Was there more to that question? Sorry, there's a few things went on beyond that. Yeah. In the team.
It was about the who's involved in that feedback loop and how to ensure that all the right voices are captured in that.
Well, our intention was to work with the service users and carers, and obviously we work really, really closely with our partners. Is there anything specifically you were wanting to suggest? I am wondering if there was something. I mean, obviously we work with the service users, the citizens, the people we work with, and we'll work on obviously their carers. We always talk to carers, assuming we have permission to do so. And then we work very closely, mostly with SHSC and some voluntary sector. That's who I would usually use feedback. Was there anything, I was wondering if there's anything you specifically wanted us to
I think in
consider.
particular, just bearing in mind the number of young people who are coming through transitions and all that we're trying to do to mitigate, kind of escalating mental health situations for young people, and how they might be involved, I guess, in what maximising independence looks like for them.
Yes. Sorry, I was grouping them into our service users, but yes, you're absolutely right. They're a really key part, because the team has a couple of different roles, actually. There is the work with the young people, but also work with other adults who are not coming through that process, who may have found themselves into a more restrictive setting. For example, they may be in a residential setting, that kind of setting. And one of the really big aims of the team is to give people who have maybe not had the attention, the support, the input that we needed them to, the chance to move on and to move into a better place, no matter how long they might have been in somewhere. So yes, it's a dual thing, but absolutely we'll be listening to young people's voices. I work very closely with some of the children's teams at the moment, because we're covering the transitions, we want to cover them better, basically, with this new team.
Can I just come in on that as well? The Maximising Independence team has a number of different roles in it as well. There's an occupational health therapist, thank you. There's also 5 support workers who are working with people on developing their life skills, as well as a social worker and social work practitioner. So a number of different roles will be doing different elements to support the young people through their development of independence.
I probably don't need this microphone because I'm quite loud anyhow, but I'll use it, pet of etiquette. I'd just like to respond to Councillor Milton's points about right care, right person. In terms of referrals to the approved mental health professionals, and for those of you who don't know what an approved mental health professional is, they're basically the social workers that have to consider compulsory admission under the framework of the Mental Health Act for people that are referred to them. So basically, we do the sectioning of people. Section 136 is a specific police power that only the police have access to, where they can remove somebody from a public place who they deem to be suffering a mental disorder and needing immediate care and attention. Right care and right person hasn't actually changed that for us. We're still seeing the roughly, very, very slightly increased numbers from the police of all our referrals. It accounts to a quarter of all our referrals is police referrals on section 136, and it is very, very slightly gone up. I think what right care, right person has done is stop the police going out to crisis situations in the community where they don't see an immediate threat to life or limb. And they're sort of very much cascading that down to mental health services in the community, maybe to us. They're wanting basically crisis teams to go out and do that. Unfortunately, that's making people go into crisis a little bit more, because not anybody that goes out, social workers, nurses, doctors, don't actually have that much power or authority over people in the community. We usually need the force of the police in order for us to get people into hospital. So right care, right person has been good for the police. It's reduced their mental health activity, but it has had a bit of an impact on other partner agencies in their ability to respond robustly to crisis. We had certainly in a situation 2 or 3 weeks back where this is exactly the case. We could go around and do an assessment, but we couldn't get the person moved lawfully without putting hands on them. We would have needed police intervention, and indeed we had to go and get a warrant to get this person, which does involve taking time and stuff like that. In responding, Councillor has also mentioned about more increased referrals from hospital and certain people getting admitted to physical, from what's a word, a physical bed. Lots of people with long-term mental health problems have lots of comorbid physical problems, so there's a good likelihood that lots of people on their inpatient wards may have a coexisting mental health problem as well. And we do get people that get admitted to hospital for a physical reason, then once they've been sort of physically treated for whatever problems that they've got, we're finding that they've got a significant mental health problem, so they end up having to unfortunately stay in the STH or the NGH hospitals in order to get treatment for their mental health. That is an issue about psychiatric beds not being available for us to detain to. We can detain to Northern General, we can detain to Sheffield teaching hospitals, and we do that, and as Tim quite rightly points out, we're seeing an increase in referrals from that agency in itself, so we're getting more direct referrals directly from Northern General, Hallamshire, less so from sort of Jessops and Charles Clifford and stuff like that. But certainly the Hallamshire and the Northern General are getting an increase in referrals from them for people with untreated mental health issues. So we're also noticing a sort of physical thing there. We're not noticing an increase in cancer. We've been talking about young people. I'll put the stats in there for you here. About 5% of the people that we see in terms of the Mental Health Act are under 18. So we've definitely got the stats for that. They're usually already in a hospital, because we do have a private hospital within the border of Sheffield, so that means that they come under our orbit and our duty, our pleasure, so to speak. So we do see quite a, that's where we see the majority of the people there. But I would also say that the people that we usually see with CAMS that are under 18 have usually got another coexisting sort of mental disorder, usually autistic spectrum disorder or learning disability as well. So the Mental Health Act really is the sort of last treatment option available. All over care treatment reviews, all other sort of safeguarding issues have usually been exhausted at that sort of point in time. I can't think, that's the bits that I wrote notes down to. If you've got any other supplementary questions, I'd be more than happy to answer them.
Could I come back to the direct payment question as well? We do use direct payments through in mental health services, and across the department I think about 30% of our personal budgets are direct payments, so we do quite well in that area. The particular scenario that you talk about where somebody gets a direct payment and then it's reviewed and perhaps haven't spent all of their personal allocation, so it gets taken off them, that does happen if people aren't spending the money that's been allocated, but we do make sure we allocate sufficient direct payment to cover their needs. So their assessed social care needs. So they still should have sufficient funding to deliver to achieve their desired outcomes. Finally, can I come back to Councillor Rooney's point, we do have a transitions register. So for every young person that's coming through from children's services to adulthood, we have, in mental health services, we have a list, if you like, of everybody coming through. And we know where they are geographically. But that's not every young person who is coming through the system, if you like, with needs. It's just the young people coming through to adult social care. It's more difficult and more challenging for us to get a register, if you like, of all young people coming through the wider system in terms of a special educational need or autism or other conditions. And I think that's what perhaps you were alluding to. We don't have that wider picture.
Thank you. I have Councillor Crosthorne and Councillor McLean, and then I'll draw a line. I think everybody's spoken, or most people have.
Thank you, Chair, and thank you for this report. I think it's very thorough and obviously been a long piece of work, so thank you for bringing it to committee. I wanted to talk through, I know it's been touched on as well, point T2.3.1 on page 41 with the amount of annual reviews that have been completed. Now, with it being 27% being completed on time, can you talk us through the full picture? I think it'd be beneficial if a layperson's reading this report to avoid any speculation and to get a full picture, as obviously most completed or all completed within 18 months is better than people waiting years. So can we get a sense of like what the average and if who's potentially been waiting the longest and what time that is? And then my second question about the maximising independence team is broadly more about safeguarding and safeguarding on a Friday. Certainly as I work in a day service, not all of the safeguarding things that come up are mental health related, but I have noticed that when there is issues on a Friday, communications with social workers and the safeguarding team can fall down, and I think that's an issue that people see across the piece. Certainly as people trying to get things in place before the weekend can be challenging. So can that be a focus to ensure coverage with this new maximising independence team to ensure that if someone has a crisis on a Friday, that that's not going to be any different to a crisis on a Monday? Thank you.
Can I take Councillor McLean as well, and then we can answer everything?
Thank you, and thanks for the report. I'll just start with a comment, because obviously we're here to talk about some significant challenges that you've got, but it is just worth noting that a lot of work has happened since the teams came in-house in 2023, and it's really good to read what you say about how the current teams are passionate, motivated and skilled, and like the sickness levels are low. So I think whilst we're talking about the significant challenge here that you're facing, is also just to recognise that context as well. So thank you for that. So my questions were also related to the same paragraph that Councillor Crosthorne has just asked about. And I just wondered if you could just explain a little bit more about what waiting well means and what that looks like in practice. And with the 186 people who are currently waiting for a social worker, is that a steady number at the moment? Is it sort of still fluctuating? And also the recruitment of the social workers, the 6 social workers, that's really good to hear. Do you know how soon they'll be sort of in situ? And do you feel that's going to be enough resource to sort of deal with the backlog? So yeah, I think that's everything. Thank you.
Okay, perhaps I'll kick off. In terms of the waiting list, so let me explain the 27% figure. So all of the people who are receiving services should have, if I'm being entirely open, an annual review. We're only getting that done in 27% of cases. That's what that figure means. Unfortunately, that's due to the recruitment and tension challenges we've got. So the 6 social workers that we recruited to yesterday, actually, will have a significant impact in improving that data. In terms of how long people are waiting, I think the average time is about 3 months, and it is too long. We're not at all happy with that performance, and we are working with the staff teams now and with the new recruitment to improve that. In terms of safeguarding on a Friday, and the MASH service operates, have all of their staff in Howden House on a Friday, so any new safeguarding coming through should be attended to immediately. In terms of the mental health teams, if there are problems getting through to the staff on a Friday, we will look into that. It shouldn't be the case. And perhaps let Tanya come in on the recruitment process for social workers and waiting well.
Okay, so the way Waiting Well works at the moment is that we ensure on a regular basis, which is not quite established at the moment, hopefully it'll be about every 3 months or every 6 months, that we make contact with the person or the referrer or both and check how they're doing and check for an update. We prioritise people on a waiting list. It's really to do effectively with risk and need. That is why some of our reviews don't get done, unfortunately, because we have to keep moving people whose risk gets high. But the waiting well means that we make contact with people, we ensure that they're linked in with other services, and we make sure that they know how to get hold of us. And we also talked about what works for them. There are people who won't call us, so we establish that and make sure that that means we then contact them at a regular basis. It's kind of there's a new waiting well project that we're just working to improve that. It's not ideal. I keep an eye on how long people have been on the waiting list, and we try and do a balance of picking people off that have been there the longest and getting them allocated. Like this week, we had 3 people who'd been there a very long time, and I made sure we got them allocated this week. We balanced that with the risk of the people whose needs need addressing now. What that can mean is that we have two duty workers on a day. So this is a lot of detail, but how it works is that they will pick off the very, very high risk ones, and then we will allocate them for longer term work. So there's a lot of operational detail. Sorry about that. That's my...
I'd like to respond to Councillor Thornton's comment about Friday working. As somebody who worked out of hours for 14 years and now sort of runs a service, I can assure you that on a Friday I make sure there are more staff, just as many staff on a Friday as what there are on other days of the week, because it's transition over into weekend, and maybe there is a higher referral rate always on a Friday because staff are going off shift. So we always ensure in the AMP team that we will always have enough, probably more staff on a Friday than we'll have on a Wednesday and Thursday, to be honest, because we know it is always going to be busy. I'd just like to make a comment about waiting well. Obviously, the clients that are waiting for a mental health assessment may not be as well as we're expecting them to be. And I'm just looking on our dashboard now, and there's 13 people actually on the board. I can see that out of those 13 people, several of those are waiting for reports because they're already an inpatient in a hospital. So it looks like there's about 8 people waiting for a mental health act assessment to consider whether or not they come into hospital. My betting is that around 5 or 6 of them will come into hospital, and 2 or 3 probably won't. But if people are put on the list for waiting for a mental health assessment, and don't get me wrong, most people who have been referred for a mental health assessment are not aware, because of their mental illness, that they've been referred for a mental health assessment. They pretty much automatically come under the crisis care component of the trust. We do know that around 80% of all our customers have some sort of contact with SHSC Trust, so they come under what's called to come in team, is the crisis at risk of admission team, so they're managed by that team. And obviously if that team can't get to them because of the risk, because of their sort of suggested violence or the complete evasion, then obviously ups their priority in terms of us trying to reach them in terms of mental health act assessment. I'm quite happy to explore any of those points, because I realise my world is not the world that everyone understands very well. So, but yeah, there is a process of managing people who are awaiting admission or assessment for admission.
Thank you. I'm sorry, okay.
It was just to go back to part of my question about whether you feel like the recruitment is going to be sufficient to deal with the backlog. Don't worry. Thank you.
Sorry, I forgot about that, didn't I? So, the real answer is we could always use more social workers, if I'm very honest. However, I think it made a significant difference to my team. So, the community teams of the 6 social workers, when fully staffed, have 12 staff in each. So 6 new people is a lot for us, actually. I think we can do it with that, especially alongside the maximising independence team. That's the key for us, really, because that particular team will pick up the reviews, and that allows us to respond to the instant, the more immediate, 2 things, the more immediate needs, or people who need more long-term input, because we do have people who, for example, we'll put something in place that doesn't work, so we need to try something else. And that's what my long-term team should be doing, working alongside people for a period of time, working with some people not for long, and then ideally, the Maximising Independence team, alongside some of its other remits, will be able to get to all those reviews so that everybody's been seen. It is a constant concern for us. So, yes, I think once we've recruited all of them, we will. We've had fantastic quality, I have to say. The three of us interviewed the last 2 days. We've had a phenomenal...
Very excited.
Yeah, very excited by that recruitment. And also the applicants, as Tim said, for our support workers, we had 250 applicants for the 5 posts. So we're having a lot of people showing an interest, and I'm really excited about it. So hopefully the answer is yes. Thank you.
I'm going to ask Matt to come in very briefly, and then we'll draw it to a close, please.
Thank you. So, firstly, I think the nature of this work can't be underestimated in terms of both the complexity and the volatility of the demand that the mental health team and the AMP service face. I know some members of the committee have been to see the service. When you witness it firsthand and you look at the skill that's required to do the job that the team does, it really does take every ounce of the professional qualifications that the team have. I think a lot of the issues we've got in performance are linked to the legacy of the exit from the Section 75. That's not pointing fingers at other organisations. There was a volume of work that had to be progressed. The legacy of that work is still having an impact now. The acuity and the complexity of mental health in Sheffield is increasing year by year, and the long-term answer to all of this cannot be recruitment. We can't continue to spend more and more money on infrastructure that the council doesn't have, but I think the focus on maximising independence is essential, and what we seem to have across the whole economy is a bit of a gap in the prevention space. So I've had an organisation called the Conversation Company approach me who want to work with the voluntary sector, look at where we do have mental health capacity already and look at what we need to grow as a city. And I think that's really important because most of the cases that Sid and Tanya and Tim are dealing with are people with long-term enduring mental health who are more often than not in a state of crisis, and the only way you do anything to stop that is upstream. Finally, in terms of Councillor Crossthorn's point, when we come to the safeguarding item at the next committee, one of the things we can do is look at demand going into the MASH on a Monday to Friday basis. So that will tell us very quickly whether or not there's an issue at scale about responsiveness. So we'll bring that evidence forward. Thank you.
Just on that, it'd be also, thank you Matt for that, it would be good to see not just about the responsiveness to the initial request, but the follow-ups as well. Certainly when providers have fed in, it's not always a point of getting a social worker involved, it's then getting that continuous feedback of what's going on throughout the day and what's being put in place. So that would be also good to see if possible. Thank you.
Thank you. We can discuss that in one of the briefings maybe before we get to that point. So thank you very much. I wanted to ask a few questions, but I can ask them separately. So the recommendations for the reports are on page 38. There are 2 sets of recommendations. The first lot is note the content of the report on community social work teams, and specifically to be aware of progress and challenges facing the team, specifically performance, recruitment and retention, hospital discharges, demand, acuity. And the second set is note the content of the appendices, the approved mental health professionals, and specifically to be aware of the following. The central AMP service is supported by 2 contingency group of staff, the bank staff who work with SSC as casual, AMP workforce who can do additional ad hoc shifts when necessary. This pool of staff will be maintained, and community AMPs who are based in other social work teams will spend 20% of their time working on the AMP rota from October 2025. And there is a demand pressure across the mental health system, particularly specialist AMP teams, and succession planning is underway to ensure a workforce fit for purpose in the longer term. Are members happy to support those recommendations? It's unanimous. Thank you. Thank you so much. I do have a few questions, but I'll drop them to at the next possible So item 10. Thank you so much. This is on page 53 of the pack, and I believe, so item 10 is Adult Marketing Commissioning Update. We have Mubarak presenting. Thank you, Mubarak.
Can you hear me? Yeah. Okay, I'll try not to break it this time.
You introduce yourself.
I will do, yes. Mubarak Darbar, Interim Commissioning Director for Commissioning and Partnerships. Okay, so I'm presenting a paper on the market sustainability and where we're up to at the moment, as well as some recommendations around apprenticeships, and gives the members and the committee an update on our quality assurance. So there are items on the recommendations to note and a couple to approve. Okay, so the Adult Social Care Commission and Partnership Service has a key role in achieving our strategic vision and priorities through the development, purchasing, monitoring of services for people in Sheffield. It's about securing sufficient care and support, provision that meets the needs of our population in a statutory requirement for all local authorities. This duty is set out in Section 5 of the Care Act 2014, recognises the high quality personalised care and support can only be achieved where there is a vibrant, responsive market of services available. In terms of the market oversight, our aim is that the market in Sheffield operates in an efficient and effective way. It is one that has a sufficient supply of high quality services and can deliver investment, innovation and choice in care and support service provision. It is a market with a sufficient skilled workforce who receive a fair rate of pay and are supported with training to have skills, knowledge to be able to meet the needs of people receiving care and support. So jump into section 2.15. A sustainable, sufficient market provider market is one where there is enough capacity to meet the current population, and we think we have that. It also indicates timely brokerage and delivery of care packages, customer satisfaction and outcomes with low or planned provider exits. Our market position at the moment in terms of fee setting for 2025-26 was presented to the March committee, and the committee agreed, and that was then we informed the providers. So following the March committee report, providers our refreshed process for provider escalation issues, the provider escalation process, and our provider failure exit plan, which explains how the council ensures continuity of care in the event of provider failure or provider exit were updated. We have since then written to all providers and included in detail our escalation process to be involved in further discussions relating to fees and quality. Our aim is to maintain effective relationships and open communication to support ongoing stability and sufficiency in the care in the city, of care in the city. This includes our established provider forums and other partnership working arrangements. 508 providers received this communication, i.e. letter, of which 33 providers had responded. This was up to end of May 2025, contacting us to engage further on matters relating to fees and sustainability. In the total, these 33 providers, 236 people are supported. Majority are residential and supported living providers with a small number of home care and day activities. Out of the 33 providers, 12 providers are in city out of city, and one provider has placements both in and out of Sheffield. 3 of supported living service providers, 2 residential providers, and are on the respective frameworks. There's a range of increases being requested from providers, and individual provider discussions are underway now with the commissioning team as part of that process we have put in place. Okay, moving on to the Care Academy, again to inform members of the committee. So the Sheffield Care Academy Recruitment Education and Support CARES, in short, has been launched in October 2024, intended to be a hub to drive collaborative development of the care sector workforce in Sheffield. This aims to address the long-standing and emerging issues affecting the adult care workforce in Sheffield. The Sheffield CARES mission is to retain, recruit and develop a strong social care workforce that delivers outstanding care for people in Sheffield. It has a focus in 3 key areas: recruitment, learning and development, and support staff. In November 2024, Sheffield City Council commissioned Care Professional Academy, CPA, to provide and affiliate the provider portal for the care sector in Sheffield. This allows staff to and managers to log and track training on development activities. Alongside this, all staff have access to the benefit schemes, which reward staff for completing training. Recent feedback suggests that access to the programme has saved providers approximately £9,000 per year on an EAP subscription. Providers feedback that recruitment is a significant cost pressure, with an average cost of £600 to £800 per recruitment. We believe that in Sheffield, the estimate total cost is around 3.6 to 4.8 million annually on recruitment. Moving on then to the Sheffield CARES Recruitment Hub. Since 2024, in partnership with ADA, Sheffield City Council has delivered the Yorkshire and Humber International Recruitment Programme. In Sheffield, this is a DHSC funded programme which facilitates the matching of overseas recruitment to sponsored work opportunities where they have been displaced by unethical practices or by sponsorship revocation. This includes the development of a public website and enabling support. Moving further down, providers in Sheffield can access bursaries to support recruitment of overseas workers too. Care providers and Home Office approved sponsors. There's a host bursaries, care provider sponsorship bursaries, and workers bursaries visa costs. Moving on to the next sort of section on the committee paper, the quality and monitoring. Sheffield Council undertakes quality assurance of adult social care market as part of its delivery to statutory duties under the Care Act. The Quality and Performance Service, led by the Quality Assurance of the Provider Market, working closely with ICB, adult safeguarding assurance teams, adult care and wellbeing commissioning teams, and internal external partners to ensure effective oversight of care provision in the city. Regular reporting provides assurance quality of market, includes monthly meetings with South Yorkshire Integrated Commissioning Board, Care Quality Commission, Inspection Manager for the area, and there are good relationships across Sheffield City Council as well as ICB, CQC at a local level, which enables us to continued response to care quality in the city. In March 2025, 86% of our care homes and 88% of our home care provision in Sheffield was rated good or outstanding, and there remains a low number of contracts handed back, none in the last 12 months. Sheffield continues to benchmark well nationally in relation to quality and stability of the market. There's also a table in the report under section 2.34 that shows the CQC rating of Sheffield compared to national average, which we are above the national average both for care homes and home care. The Council has implemented embargoes and restrictions in relation to quality and safeguarding concerns as part of the quality assurance and risk escalation framework. These are quite low. In the last 12 months, we've had, since up to March 2025, there are a total of 7 embargoes. Most of these embargoes were brief and progress to manage restrictions to entry into provision. And there's also a table in section 2.37 that gives an overview in terms of where the escalation processes are. As you can see, the vast majority of providers are rated green. 259 providers across all categories are rated as green. Yellow, 8, 4 amber, and only 1 in red, which is under the embargo. And equally, even though we may not have contracts with direct award providers, again, the numbers are quite good in terms of green and yellow. So moving to 2.38, the Quality and Performance Team monitor action plans to address areas of concerns identified when provider visits, agreeing with manager time.
Sorry, Mubarak, I think you can assume that people have read the report, so we can ask questions because, is that okay? Thank you.
Fine.
Yeah,
I'm more than happy
we just need a few points just for people out there. The papers are published, members have read the report, so we can concentrate on questions if you don't mind. It's just we went a bit longer on the other item, and I'm trying to catch up on time. So can I ask colleague please to be really concise, and I have allocated a certain amount of time to this report. So I have Councillor Milson, I want to ask a question, and Councillor McLean.
Thank you very much. No, thanks, Mubarak. Really quick comment, just that I think the local recruitment hub is really, really key, and the way that will work in an integrated way with the Care Academy. I just wanted to comment, I think that's a really important piece of work for us to watch, and be really interested to hear Chair some updates, like fairly regular updates on that, maybe in our briefings. But as that gets started, the recruitment hub, to hear how that's progressing, because it seems like a really important part of the trajectory away from reliance on international recruits and professionalising the care sector in this country. Also, just wanted to comment that just thinking about more widely about what the most cost-effective ways are for us to meet our obligations of the Care Act. And obviously so much work has happened over the last few years about market shaping, and we've been following market position statements. Just thinking really whether the market position statement as it is today indicates that as a council we could consider other types of provider and delivery, such as cooperatives and non-profits, to further shape the market. So should we be considering shaping the market in that way?
All right, can I take Councillor McLean's question and then you can answer both? Is that okay?
Sure. Thank you. Thanks, Mubarak, for the report. I've got a couple of questions. The first one was about the new market position statement, and it talks in the report about how it's been consulted on with providers, stakeholders, and partner organisations. And I just wondered if that includes users in some way of services. And then my other questions are about the Care Academy stuff, which sounds great, about the employee assistance programme and then the upcoming Cares Recruitment Hub. At the provider events, forums that have been held in the last few months, we've very much heard from providers that things like this would be really beneficial to the sector in Sheffield. So it's really good to hear that's underway. And I guess I just wondered what the uptake from the sector is. Do you feel like providers across the city are engaging with the Care Academy? And if not, is there more that needs to be done to sort of publicise that and sort of really engage providers with it so that they're using it, because we know that it'll benefit everybody. And then I just wanted to quickly ask as well about, you mentioned the embargoes, that there's been a small number of embargoes in the last 12 months. And I just wondered, in terms of the reason for the embargoes, are there like common issues, or is it a mixture of things, or is there a pattern of things that providers are struggling with that are leading to the embargoes? Thank you.
I've lost my question as well because it's got to do with the Cares Academy, and I wanted to ask, just remind us what the long-term plans are for the Cares Academy. So obviously the council is committed to paying for the platform, but what's going to happen, you know, long-term?
Sure. Okay, so I'll start off with Councillor Wilson. Yeah, we will provide regular updates. There's absolutely no problem on the professionalising the market sector, and well, giving the information on the Care Academy. You mentioned about new ways of working and working with non-profit organisations, and yeah, we're always looking at innovative ways and creative ways of working. I think there's more that we can do, I think, you know, certainly. Collaboration work, we haven't really explored that much because of how frameworks work, procurements and so on. However, we are doing a lot of work at the moment with housing providers, care providers, developers around collaboration. So I came last year, brought a paper on care suites and different models, and we've had several events with housing associations and care providers, and that's been really fruitful because and developers, and they've been talking to each other, and that's created real energy and some really, really interesting kind of proposals or ideas are coming out of that. So that having that platform, having those events, creating the opportunity is the way forward. And I think we need to do more of that, and maybe think really outside the box around the next level of, you know, not-for-profit organisations and others. We have a pretty good sector for, you know, working with groups, voluntary groups, organisations, charitable organisations, in some of the kind of peripheral stuff, maybe not so much in the care side, but maybe that's something that we can look into further. Yeah. So moving on to Councillor Kelly. Yeah. To answer your question, absolutely. I think we need to do. The Care Academy is really successful. We had a slow start at the beginning in terms of engagement, but now it's really, really picks up, you know, we involve care providers in the provider forums that we have, the adults partnership meetings that we have with care providers, so and their representation as well. So yeah, slow start, but it's working well. Yeah. Embargoes, you mentioned embargoes, correct? Yeah. So in terms of the kind of, it varies from provider to provider. You know, we've not had many embargoes. Often it's about response. You know, social workers picking things up, commissioners picking things up. You know, and then we ask the providers, and they come back to us. You know, this needs looking at. Or we're unhappy about this, or you need to correct this, or you need to improve on this. And when things aren't happening to the pace that we want it to happen, at that point we would then escalate it into a provider escalation process, and then within that there's processes that you would expect it to follow, and ultimately could lead on to an embargo because we believe the providers aren't responding at a timely fashion. And you know, we have pretty regular meetings, expectations, there's an action plan put together, and we expect them to be delivering on that action plan within the time that we've asked them to complete. So all of that happens in a very structured way. Occasionally you may get safeguardings that we have to follow that through, and that then leads to an embargo. But generally we have a pretty good relationship with our providers. Our officers are very much engaged with providers on a regular basis. We tend to have a pretty good sort of finger on the pulse in terms of, you know, where things are with providers. Was there another question you asked?
There was just the question about whether when the market position statement has been consulted on, whether users are involved in the way that's been consulted on at all. Thank you. Yeah, of course. So the market position, so it's gone through
different stages. So the first stage was engaging with the providers, understanding demand, supply, growth, expectation, and we sort of concluding on that sort of stage. And we have engaged with some service users, but I think we need to do a bit more on that now. Now we're in that place where we've got a product that we can take to our service users, people who use the services. Because the nature of the document that was provider focused, it was very much engaging with that sector. We have offices that we're working on this in the various disciplines, so care homes, supported living, home care, and they've been working with service users on a regular basis. They've been inputting into the market positioning statement. So there's been involvement on building the market positioning statement. I think the next level is we can maybe take it to the service users as an end product. Yeah. Thank you.
Yeah, I'd asked about what the long-term plans for the Care Academies are. And after that, I'm going to take Councillor Aries and Councillor Rooney's, and then we'll draw it to a close. Thank you.
Sure. Well, the plans will continue with the Care Academy. The long-term plans is we want to work with the sector, grow the Care Academy. I think clearly there's ultimately, ideally, you want the Care Academy to be self-sufficient, and the care sector sort of taking that on and leading on that. Our intention was always to kickstart this and to sort of be that conduit to bring it together. So the next stage would be to sort of evolve this into ideally a self-sufficient sort of running type of sort of, and there are good examples of that across the country where lots of providers, sort of provider forums in areas have then done that and then tapped into various funding streams and so on to sort of keep it sustained. Yeah.
Councillor Aries, thank you.
Thank you, Chair. My question, excuse me, my question was about the Yorkshire and Humber International Recruitment Programme at the bottom of page 59, the very last paragraph there. I wasn't really aware of this, but how long is that project for? Can you just enlighten me on, just from my personal knowledge, how long that programme is for? And is that likely to continue beyond the current financial year?
Yeah, I think we've got funding for 12 months, maybe a bit longer for that. And it's direct response to the situation where some international recruitment staff have come to the country and then resulted, for lots of reasons, unscrupulous providers sometimes, or their sort of contract ended, and they're suddenly unable to get work, and they are part of the sort of international recruitment as a opportunity to pool of staff that providers can tap into. We've had some successes already. We've had, I think, one provider needed 5 staff, and they've been successful in getting these staff from this initiative in Sheffield. So it is time limited. We've got the funding at the moment, but it is time limited. I think I can come back to you. I think it's either 12 months or 24 months. Yeah.
Thank you very much. Couple of questions. One is, what is the threshold in terms of a provider being embargoed? What do they have to do to be embargoed? And the other one is in terms of trying to get a rounded view on whether about quality assurance. Do you involve the trade unions? Do you ask their opinion? And do you actually talk to the staff employed by the providers so that we get a rounded view, not just the provider's view, but a rounded one, please?
Yeah, no, very good point you raised. So we do have an escalation process that would look at how a provider becomes or gets on the embargo list. And it's not done in isolation, it's done with engagement with all our officers, so social workers are involved, safeguarding team, external partners, of course, people who use the services and family and carers. And it's got to be a matter that's concern to us. And embargoes can, often the kind of short term, because ultimately, these are our own processes. They are CQC regulated, so they are providers that are, eligible to provide care and support. But our quality standards is about us feeling comfortable that, are they meeting the grade that we expect them to meet? So there are several reasons why we would put them in an embargo, often mainly safety of the individual. And to answer your question around staff, absolutely, we have spot checks, unannounced checks. We talk to staff managers, look at the, how staff talk to people with people use the services. All of those things are then collected. I had an escalation meeting the other day, and we had officers, from operation, commissioning, quality, social work, and all their views were really important because that shaped our kind of, sort of outcome of what then needed to happen. At that point, then we would engage with the provider, often the director of the organisation, the regional manager, and the registered manager would be part of those conversations. Generally, they accept it. They accept that there is a fault or a problem, and often providers will to respond to us positively and make those appropriate changes. Sometimes to do with staff turnover, sometimes to do with new people coming into the property, and that creates an imbalance into that equilibrium, and that then creates friction. So there's lots of reasons why it could happen, but our aim is to try to get back to a place where everybody's safe and and providers are responding appropriately. That's the important thing.
Thank you. I'm going to draw that to a close. The recommendations for this report are on page 54. In pre-meeting on Monday, we just made a change to some of the wording in the recommendations. So in 1, 2 and 6, we are going to change the words inform the committee to note. So the recommendations are as follow. Adult Health and Social Care Policy Committee is recommended to note the progress of on refreshing the market position statement 25-26, to note the ongoing work and position in meeting our statutory duty under Care Act 2014, to ensure market oversight and market sustainability, to note the progress and update on quality monitoring and assurance, approve the fee recommendation for the council delivery of a partnership, and approve an uplift to current fees for property searches, property storage and estate handling. And the last one is to note the latest position from HMRC on VAT. Are members happy to support those recommendations? Thank you. I believe it's unanimous. Thank you. So thank you so much, Mubarak. We are moving on to item 11, which is on page 77, and it's adults, early intervention and prevention. And we have Martin, who will introduce himself properly. Martin, sorry, could you put the other one down so we don't have two names? Thank you. It's just for the camera. Thank you.
Morning, everybody. I'm Martin Smith. I'm Assistant Director of Planning and Partnerships, and a joint role between the Council and the ICB. And I jointly lead this with the Assistant Director of Home First, Kelly Kofarski, in terms of early help, and a lot of the early help prevention work is within the joint area in the Better Care Fund. I'll assume everyone's read the report, so I will just go through and then happy to take any questions. But the purpose of the report is to provide an update on the early intervention and prevention activities and outline some of the key work we've been doing and our next steps. I think everybody's probably heard it a million times, but it's really about there are some challenges in Sheffield in terms of social challenges, health challenges. We've got some in the pack around obesity, air quality, and the early intervention and prevention work is about tackling some of those causes with public health. So it needs to be a partnership approach with communities, with public health, with our residents and with the NHS to try and tackle some of these. And prevention is a crucial part of our adult social care offer. It is within the Care Act that in terms of adults, we need to look after people who don't have any current needs for care and support, who may not be eligible, and specifically carers. So we have a duty to try and support and prevent things and reduce things so they don't escalate, to keep people at home and with environments that they can live in and love, and to have services that are accessible to them. And in terms of that partnership approach, we're working really closely with Future Sheffield, because we recognise that city goals set an aspiration around thriving communities. The council plan sets an aspiration around caring, engaged communities. The adult strategy, our strategy, has priority 6 all around it. Customer experience strategy and the community strategy all recognise the importance of communities and early help. So and the ICB strategy the same. So we are working in a framework, not in isolation, with our partners around what services are available, how do we link them up, how do we not duplicate in adults to support people to have one way into services. We've set up a presentation, it's within the pack, and happy to take any questions on that, but we want to use that as the basis of our discussions going forward. So we've got events lined up with partners, we're hoping that those events enable us to collate current views on the delivery of the services we currently provide and what's currently out there, and we're going to use that to evaluate our current offer and see what we need to add into our delivery plan going forward. As I said, we work really closely with partners, the smoking, healthy weight, alcohol, the communities, the falls provision with NHS and Yorkshire Ambulance Service, and we're looking at optimising our care with equipment services and disabled facilities grants, and first contact advice, how we use tech to enable some of these as well. So I'll just briefly touch, it's in the paper, but I'll briefly touch on the 6 work streams that are under this programme, 6 big ones. So one of those is unpaid carers. We have a multi-agency carers strategy that we work on with partners, and it was Carers Week last week. We did a joint event, we did a number of joint events, but we did one in the fire station with Age UK and the NHS, and we're doing blood pressure checks and supporting people and providing information. And we've recently signed a memorandum of understanding for no wrong door for young carers. So if any young carers identified through any of our services, that they're not said, oh, sorry, we can't help you here, that we've got an agreement across that. In terms of equipment adaptations and occupational therapy, we continue our work. We've reduced the waiting times for occupational therapy. Kelly and the teams have done some amazing work with people around that. We've also launched our independent living centre and our new approach to waiting well for those people who are on the waiting list. And we've recently established, in terms of our equipment service, a partnership quality performance report where we're asking the providers and the prescribers around what efficiencies we could be making to make it easier for people not have too much equipment at home, to have duplicated equipment. Again, we're looking at how we support people to be independent, but also to try and reduce some of the cost in the services by not duplicating orders. Tech-enabled care, we've worked to develop a blueprint, sets out a proposal around tech. There's a lot of interesting areas around AI and magic notes that we're linking into the Future Sheffield programme again, and trying to bring the adult social care workforce forward in terms of what we can do with the tech that's available currently. Home First, we've launched our Home First. You may have already heard about the suite of services, incorporating things like our first contact, short-term intervention, therapy, technologies, and the equipment services. And the next step will be to continue to develop the services in line with the diagnostic. We did a recent diagnostic around what we need to do differently, and multidisciplinary teams working in the neighbourhood models. There's a lot we can do, and we're working very closely with health and with our partners around how Home First fits into the community model and keeps people in their homes. Falls prevention, we did a presentation a few months ago at Health and Wellbeing Board around falls, a joint work around falls, but citywide care alarms have secured additional funding to keep it going. Again, this work is around working with the Yorkshire Ambulance Service, who can refer in now if somebody needs a pickup, somebody's had their last care call, if they would use the routine or they couldn't access the phone, they might not be seen until the morning. We've got lots of good evidence on how this service is really supporting people and not taking them into hospital unnecessarily. The final one is about promoting independence by providers, about supporting providers to work differently, and we've launched our optimised care work, which is about single-handed work, how we use equipment, how we don't have double-up teams, again, to empower teams to be and people to be as independent as possible, and the safe moving and handling that goes with that. So finally, just the next step, some of the things we'll be working on going forward is around improving our information, advice and guidance offer through Future Sheffield and our digital transformation and customer service journey work. We're working through that integrated neighbourhood models guidance and how we work with sort of our NHS partners and community partners around how this model can be rolled out. We're looking at strength-based mental health offer, tech-first approach, and again, looking at our strengthening our reablement offer, and we've got a new specification for our STIT service that we're doing jointly with health. I'm sorry, it's a bit of a whistle-stop tour, but that's all I wanted to say. I'm so happy to take any questions on our early help work. Thank you.
Thanks, Martin. I have Councillor Dunn first.
Yeah, thank you. Thank you for the report. How are we working with our adaptations department? Because to stay in your home, to be as healthy, needs a responsive adaptations, and we know that has challenges, and I mean especially with our own council department, but as we know, so many people do live in housing associations and in their own homes. So if you could expand on that, I'd be really, because I know that my own caseload as a councillor, a lot of it comes from that. So, yeah.
So the Disabled Facilities Grant and the adaptations are within the sort of Home First work within this area. Now, Kelly will probably be able to tell you in more detail all the work, but I know we've been doing a lot of work looking through how our criteria for using the Disabled Facilities Grant and how we're applying it, what we're doing. There was a long waiting list for a while on that, and it has come right down in terms of the work we're doing. I can bring that back in terms of more information on it, but that is within our Home First. So that is equipment and adaptations is within all the work around early intervention and prevention, and we have been focusing on the Disabled Facilities Grant and how we improve the service and what we do with it.
Lovely. Second question is about dementia and the support at home. Bit close to my heart. I do a lot of work with dementia in my own ward, and slightly in the last presentation that we had, but really kind of, again, the support that we're putting in. Does that fit into the Home First as well? Because so many want to keep their loved one with them as long as possible, but they do need a little bit more help in that. So
in terms of dementia and dementia services, the Home First is probably more specific around what are the current service offers, but we do link to all those first contact early prevention services, so all the services that are in Sheffield in terms of supporting people at home doing that, and then we link closely with our colleagues in the mental health, because we've just signed up to a joint dementia strategy, so how we deliver and support people diagnosed dementia earlier, what support's available. We're trying to ensure that we use our tech, so all those services are available, so people know what's available currently. But you're saying if it's a progressive part, then they might tip into some of these services.
Final question on that. Sorry, just about you meant our tech. When people are older, often they're not as IT savvy. So it was just to make the comment there that it's important that we are reaching further afield on that. Thank you.
Thank you. Can I ask members please to ask all the questions, and then Martin can answer. Councillor Gilligan-Cuba.
Thank you, Chair, and thank you, Martin. I really like this policy. I think it's a great idea and a lovely vision. And I'm going to apologise if my question's not the right one, because it's my first time on this committee, so I might be asking stupid questions. And it comes to me because I have some casework myself in my ward about an adult who has learning difficulties, so probably in their 40s now, supported by very, very elderly parents. At the moment, they're managing well. They have some access, some carer coming in for cleaning and things. But at some point, the parents are not going to be able to do this, and they don't have any IT access, any of them, so they've been managing. I go in and sort out a lot of things for them now because they need IT in this modern world and they don't have it, filling in forms. How do these kind of people get some help when it's going to be needed, because the adult in person won't contact anybody because she doesn't really communicate and do. She can go to work but doesn't really have any ability to go out and ask for help and things because she relies on her parents. What happens when the parents are no longer there? How do they get picked up is really what I'm saying.
I think you make a really important point in terms of, so how do we, and this is what we talk about, I suppose we do it in care homes as well, so there may be other professionals that are going into that house. You know, it might be healthcare professionals who might be getting support. So it's through our early help and prevention offer that we try and do that. It's almost no wrong front door for any services to identify vulnerable, vulnerable. So the worst thing in that case would be, care breakdown. So that's like emergency support needed to support the individual if one of the parents went in. But we're trying to work with. That's why we're trying to do all the Future Sheffield work with all the teams that go into people's houses, and if they identify people, so if she could do, we would say, there's lots of services available. Here's a directory. But it's about all the teams having an eye on everyone, saying, I think they may be vulnerable, and they would be eligible for a carer's assessment. You don't have to have that needs. That they would have a carer's assessment to say, okay, what, and then a care plan or sort of plan will be put in place for that individual to know, right, if that were to happen, where would we, what provision have we got? But it is about joining up with our professionals across all services to identify them.
So I don't think they have any professionals going in at the moment. So would it be a good recommendation for me to suggest they get some carers to give them an assessment? Yeah, that would be a way to start.
Okay. Councillor McLean and then Councillor Milson. Can I have both ask the question? Thank you.
Of course, thank you. Thank you for your report. I just had two questions. The first was about paragraph 2.7.3 on page 82. You talk about there's going to be some further work completed to engage with people with lived experience to look at any gaps in our provision, and that sounds great. I just wondered if you knew a bit more about what that was going to look like and the shape of it. And then just sort of more generally with the early help and prevention work that we're doing, well, how are we measuring outcomes? How are we showing that what we're doing is having an impact? I'd just be interested to hear your thoughts. Thank you.
Councillor Mills.
Thank you. Just in response to Councillor Gilligan-Cuba's point, what I would do if I had awareness of a situation like that in my ward is probably put them in touch with the Carers Centre. So Sheffield Carers Centre is that's our front door for people who aren't yet in the system and just need support and advice. Is that, yeah, correct? And I think the fact that you don't know about it puts a burden on all of us to make sure that all our colleagues know about it. So that's something, I'm taking that away. I should make more effort to, yeah, because that's our best resource. I asked AI, how does Sheffield compare with other core cities in terms of delivering on prevention and early intervention in adult social care? The answers were very positive. So congratulations. So we're positioning ourselves as a leader, apparently, and there's a lot of evidence to support that claim. So I think that's really positive for us and for all the work that's been done over recent years. Having said that, in terms of really digging into prevention, some of the steps that are outlined, I think, are quite delivery-based. And I think we can still make a massive quantum shift really into the kind of community-centric preventative measures and really joining all that up. So without going into too much detail, what I've read around is examples from Birmingham, where their emphasis is very community-rooted, things like healthy living initiatives and backing up public health campaigns, putting in community health centres, things like that. And just noting, we've got our local area committees, which are probably being quite underused in that respect, in that we've got a council mechanism for getting information, help, drop-ins, that can be rooted in our communities and more visible and accessible for people. So just wanted to comment on all that really, and also just to comment that although the ICB is technically committed to prevention, I think they struggle with releasing resources. So the North East Model Neighbourhood is an example of the NHS releasing some resource, not as much as we wanted, but let's see how far that goes, and can we take the learning from that on a step-by-step kind of basis, Chair? I'd be really keen to hear regular reports back on the North East Model Neighbourhood as it goes along, like not wait 5 years and get a retrospective report, but hear about it as it's unfolding, because there could be things we can duplicate in other parts of the city.
Yes.
Thanks.
Yeah, we could add it. Would you want me to add it to the work programme?
I really like that, yeah.
Let's have a conversation in a briefing about that. Martin, I'll let you respond to the rest.
Thank you. Thank you for the questions. Really good questions. In terms of people with lived experience, we're working with our comms and engagement team to identify who they are. They're going to be invited to the events, so we can hear, how, we've got those events planned around how you're currently accessing services, what are the challenges you've currently got, so that we can refresh the delivery plan based on what people have said is working and not working. In terms of outcomes, it has been a difficult area in terms of outcomes because it's so broad. We did have a number of goes at outcomes frameworks, and so we've been working with the North East Sheffield work because they've just done a big consultation with communities around what matters to them. We've also got a number of public health outcome framework measures. We've got outcome frameworks around outcomes around how supported people feel in terms of the adult social care outcomes framework. So we are having a look, we're going to sort of do a refresh of that in terms of our early help work. We do have key measures that we measure ourselves through, normally through the adult social care outcomes framework or the public health outcome frameworks, but they don't always represent or maybe have the outcomes we want to see from communities, a bit like what you were saying around the North East and what people are doing differently. So we recognise we need a better outcomes framework around that. Came out of the peer review as well in terms of what we're doing and the impact we're making.
Sounds really positive. And just to add, if there's ever any of those events that you're putting on and you think it'd be appropriate for members to come along, do invite us, do let us know about it, and we'd be happy to support.
I think the other one was just about the community centre model or the North East model. So happy, yeah, so the North East model also gets, there's an update that comes to the healthcare partnership, so that tomorrow, so we could almost, either share it or bring it on the agenda as well. Thank you.
Thank you. Yeah, and just a comment from me. It's interesting to see, I was in a future Sheffield meeting yesterday, and it's really interesting that as one of the biggest, tier 1 policy, the fair and healthy Sheffield plan is not on that page. So I've made a note to ask them why it's not there, because that links everything. So our commitment that we've made as a partnership, as a city, about how we want to do prevention. So it would be really good to kind of include that. I'm going to draw this to a close. The recommendations are on page 78. In pre-meeting, we just made a couple of changes to the wording, where it is recommended that the adult health and add the word social care policy committee, because that's the name of the committee. And then first recommendation is to support the ongoing development work aligned to promoting early help and prevention across the city to prevent, reduce and delay the onset of social care needs as set out in the delivery plan. And this is where we've changed this slightly. We add in at the beginning notes that The report outlines the key ongoing priorities in supporting our workforce across place to develop our adults prevention and early intervention approach to prior to the onset of social care needs across the local authority and its partners. I don't know if that makes any sense, but yeah, notes that goes at the beginning of that. Thank you. Are members happy to agree on those recommendations? It is unanimous. Thank you so much, Martin. And we are on item 12, which is our DAS report. And I believe normally we have people go in there. Can you stay there? Or does he need to go there? Are members happy for Matt to stay where he is? Yeah, it makes no difference. The camera is going to follow him anyway. So it's on page 107 of the pack.
Happy to sit wherever the committee wishes me to sit. Okay, thank you, Chair. I didn't get to contribute this to the last item, but what we'll do, not just for new members of the committee, but for all councillors, we'll recirculate the induction pack for adult social care. And I think Councillor Milson made an excellent point about the support tools that need to be clear. So we'll get stuff out about the carers offer. There's a whole raft of other useful contact details that will be a key part of your toolkit in the context of your ward work. So I'll take responsibility to get that sorted. On to this particular paper. So the purpose of it is twofold. Firstly, it's to make sure that where there have been previous actions discussed by the committee, there's a clear account of what's been done. Secondly, it's a bit of a state of the nation, really, in terms of everything going on in adult social care and wellbeing at the moment. I would like to thank this committee and all the team for the warm welcome to Sheffield. It's an extremely welcoming and inclusive place, and it's been really helpful in terms of getting to know people, so thank you all. There's 4 focuses that I've got before the end of October. So number 1, and you've heard some of this today, is to make sure that our services are safe and statutorily compliant. That's the basic bread and butter of a Director of Adult Social Care, but it is the most important part of the work. Secondly, to make sure that our use of resources is sustainable and that there's a strong budgetary grip. And there are challenges across the country at the moment in terms of resourcing adult social care. So it's really important we're clear on the impact of every pound that's going out the door. Thirdly, culture of continuous improvement, and that means clear and evidence-based information, not just about the CQC inspection, but actually about the wider performance of the Directorate. So if we're saying we're continually improving, we need to be able to account for that and evidence it. And then finally, in terms of the leadership team themselves, DLT as they're known, we want to build on the considerable talent that's there, build confidence and make sure that team is as high performing and high functioning as it can be. I welcome the shift in this programme to moving to key risk. It's important that we do prioritise our energies on dealing with key risks and making positive changes as we move forwards, and I think that the work plan does reflect that shift. So onto the main body of the report then. I'm not going to read it out word for word. There are 2 things in life that drive people to sleep. Firstly, it's scripts that are sat there in front of you, and secondly, it's PowerPoint slide decks that take about 200 clicks to get through and a very gentle snooze at the back end of it. So I'm going to pull out the headlines, and they are as follows. So demand for care is increasing, as you've heard through all the presentations today. In the last period, positively, not all of that increased demand is translating into Care Act eligible support within the Directorate. So that is a good sign that our signposting is improving. Our information advice, which we know has to improve, is starting to get better, but there is more work to be done. And also that more people are accessing those prevention services, some of which you've heard detailed here today. They're all very healthy green shoots. You'll see in the report there's no wait for care home placements. I think the market's at 87% capacity at the moment. That is not the case everywhere. You have a lot of provider fragility in other councils, and you don't have those kind of margins in terms of capacity, so that's good for Sheffield. And performance on access to domiciliary care since the new tender's gone in is improving significantly week on week. That's all good news. So the LGA peer review in December has been a useful consultancy exercise. What I've been doing since I arrived here is looking at how some of those recommendations have been translated into practice. Most recently this week we focused on the logistical stuff for CQC. So are we clear about where people are being hosted? Have we got the nuts and bolts like IT access, data? Is there going to be refreshments in the room? All that kind of small, soft stuff that makes people feel welcomed is in hand. I'll come on to talk about the broader preparations for CQC shortly. The partnership board was launched. I think it was the second day I was in Sheffield. We had a launch in this building. There are 4 strands that come off that partnership board, all of which I think are going to be very helpful. If you think back what you've heard about mental health, about the commissioned marketplace, and about prevention services, the 4 priorities for that partnership board is unpaid care, prevention, the care workforce, and sustainability. And they're the key challenges that not just the council face, but the whole system is facing. So having everybody in the room engaging in that debate, working collectively, I'm looking forward to that now translating into projects and activities that we can show the committee that hopefully will help everybody across the city in terms of the challenges we face. The Yorkshire and Humber Shared Care Record is now live. We already have 620 staff accessing that system. Any of you who know the intricacies of data protection and information governance will know that that's not an easy thing to do, but it has been done and it's implemented. On performance, our ASCOF, that's the Adult Social Care Outcomes Framework, that shows that we have improved on 5 out of 8 of the key indicators on a year-on-year basis. So going back to that early challenge I set out about are we continually improving, there's evidence there that we are. And what that means in practice, fewer care home admissions per 100,000 people, continued reduction in the occupational therapy waiting list, reductions in people occupying acute beds, which is a key performance metric for not just ourselves but the NHS, particularly those people who are discharge ready. On to our challenges then. There's more work needed in relation to deprivation of liberty safeguard waiting lists. And Sid and Tanya and Tim, who were here earlier, have already met with me. We've gone through, looked at those waiting lists. It's just gone. Am I boring the microphone? Come back. We've made sure that we've got very clear criteria about red and amber and green weights and what that means. A very clear focused plan to start reducing those weights moving forwards. We're doing some interesting work on Care Act assessments. So from the point that somebody gets through the door and the assessment starts to the date of completion, we do some really deep data analysis to understand the reasons for those weights. Not all of those weights are bad things. So for instance, people coming through transitions, those assessments should take a lengthier period of time to get right. That will involve multiple points of contact. So we're getting underneath the data, identifying those categories by theme, and going forwards, what I'd like to do is table really clear performance data that sets out the impact of that work, so you as a committee can both scrutinise and ask questions about why we are where we are. Annual reviews we've already touched on, so we have clear plans to improve that position within mental health, and that needs to improve at pace. But also there is a review strategy that Richard, our Director of Operational Services, is leading that will focus on a service-by-service basis to make sure that when we say we're using the Waiting Well guidance, that's a document that's used right the way across Yorkshire and the Humberside, that there's evidence that shows that if we're not getting there straight away, we've had contact, forgive me, we've got regular communication, we've got open dialogue with the individual themselves or the family member where appropriate, and we're managing that sensibly and safely. Work's also going on to improve access to information and advice. And what the local people have said, that isn't as straightforward as it needs to be. That, I think, means lots of work in a co-production space. So what do people with different needs need to access? How do we adapt what we communicate so that it's relevant, so people get it at the right time, and so that it's clear? There is a lot of mitigation detail on each one of those performance issues in the report on page 117 to 18. I'm not going to read all of that stuff to you, but I'm happy to answer the questions that you will have. So on to the CQC themselves. Our self-assessment and our data pack have been submitted on the deadline. It's unlikely that the inspection will take place in July because we know that a lot of those slots are now booked and the authorities concerned have been notified. But it is possible that the CQC arrives in August or September. We will arrange a session for all members of the committee who want to understand more about that process, more about your roles as committee members, and those of you who will be interviewed individually will already have dates in your diary for a very detailed briefing from me about what that entails, what the key criteria in the framework are, what questions are likely to be asked, and the evidence that's already been made available to this committee that can help you to inform your responses. I have started because this is a huge directorate and it won't be possible, unfortunately, for me to have met every employee in every service before the CQC land. So what I've done is set up a really simple drop-in at 9 o'clock every Friday morning that all the team are welcome to come and join in. And that's just an open Q&A session. And that's been really interesting because what you realise is that myths in all organisations become fact over a period of time, and actually some of the concerns that people have had are very easily addressed, and the expectations of people coming forwards as well are super clear. So all we need for people to do when they're participating in that process is talk about what they do, talk about the difference it makes, and talk about why it's important to them to work in this city. And I guarantee you, if people do those three things, then they will come across credibly and they will showcase the importance of the work that we're doing as a directorate. And I'm absolutely confident. We've had loads of lovely examples come forward to the work that people are involved in. That's exactly the kind of stuff that the Care Quality Commission will want to hear. They want to hear about people. They want to hear about carers. They want to hear about the impact that we're making on people's lives. They want us, where things aren't perfect, to be honest about those issues and talk about what we're doing about them. And that should be reflected in the conversation and the content that's come into this committee. So I think the focus for us as a service is fundamentally about being calm, being clear, having the evidence at people's fingertips, and empowering people to come forwards. This doesn't need to be a stage-managed process. It needs to be a reflection of where we are and what we're doing. Moving forwards, I will be bringing more granular detail about the performance. So I've gone through it verbally quite quickly. We've got no fewer than 42 performance dashboards. We've got real-time data. What I want to be doing is putting that up on the screens. I'll deal with it by exception, so I expect to be held to account for the stuff that's in red. We can talk about the stuff that's in amber or green if you wish. It's for you to choose as a committee where you want to focus. But what I want to do is make sure that you are clear on every risk that we're trying to manage, what we're doing about it, and whether we are being successful or not. We're not striving for perfection. We're trying to do the best we can with what we've got. And I think the story that you heard from mental health was emblematic of that. There's long roads ahead, but there's a clear commitment, passion and enthusiasm to do what we need to do in that area, and that's what we want at scale everywhere. I also wanted to say that I welcome feedback from all of you as committee members. Things need to be clear, they need to be accessible, and they need to be interesting. And if they're not those three things, it will affect your ability to be able to challenge. So if there's anything that you want to feedback, please do. It's open door, and I welcome that. I'm happy to take any questions before we move to the recommendations, Chair. So sorry for going through at pace. The details in the report, over to you.
Are there any questions from members? Councillor O'Neill.
Microphone. Thanks ever so much, Matt. Just on the Adult Partnership Board, I've probably been asleep, I just seem to have had a blank on this before hearing about it in this report. I've probably just not paid attention somewhere, but I've got some catching up to do on that. I've read about, I've seen the Sheffield University press release about the launch into the active phase of it. Didn't know anything about the development phase of that. So that's of great interest. I just wonder, are there opportunities for members to be involved in those work streams? I mean, personally, I'd be very, very interested in the unpaid carers and prevention work streams. So, yeah, is that open to members to get involved?
I think the whole emphasis of that partnership is getting as many people involved as possible to drive the work. So, to be completely honest, we're at the stage where we've literally just got the priorities set. There will be some emergent strands of work that are coming to the board next week that talk about the what, but in terms of the potential for people to get involved, anything that moves it forwards is helpful. So I'm more than happy to provide more detail about where things are and then what those opportunities look like in the future.
Would that be something that would be communicated to all members, like not just members of this committee? As you know, there are members who have particular fields of expertise and experience who might be very interested in that kind of work.
Yeah, I mean, if it's helpful, we can do a comms on exactly where things are at this particular stage in time. But the feeling in that room is actually not all places have this board. Apologies, you weren't briefed on the background to it. I don't know why that was, but it's quite difficult getting all those different organisations and groups in the room, and you've got a good cross-section of Sheffield there. So whilst there's goodwill, now is the time to try and translate that into practical stuff. Yeah.
I can add to that, actually, because I've been involved with it from the beginning, and it's just come to being, you know, like a proper board. So I think there are plans probably to involve other people. So yeah, maybe we can have maybe something on a briefing, one of our Wednesday, and see how we want to do it. But it is a partnership, so it's not of the council, it's the council with partners. So it's how it's been set out by people who've been involved. You know, I have been involved at different periods when I've been invited to little bits, but I'm sure they would really appreciate other members getting involved. I'm sure they would be very positive about that. Thank you. Councillor McLean.
Thank you. Thank you for the report as well. Just it was really good to see all the performance data. That's really helpful. And I was going to ask some questions, but you already answered them about dolls and things. So thank you for that. There's just one metric I wanted to pick up. So my modern Gov app's just gone. It's gone to the wrong bit. There we go. It was the bit in paragraph 2.14.14 about the actions about care act reviews that are going to happen in the coming month. And just the one about the action to complete all reviews outstanding that are over 3 years within 8 weeks. And that's really good to see that's a priority, because obviously they've been waiting a long time. But presumably when that's hopefully been completed, will we then look to sort of perhaps move on the ones that sort of just less than 3 years? Sort of, will there be a next step?
Yeah, I can give you some assurance in that space. So there's been a lot of work done on data cleaning. We have I think it's a fortnightly data report. It may be monthly, I'll double check, that comes through to DLT, the Directorate Leadership Team, that provides a granular breakdown of all of those weights, whether it's within 12 months, 24 months or above. Service managers go through all the cases that are 2 years and over. That number's come down significantly. There are some complex reasons in terms of why those reviews have not happened. And without getting into individual cases, some of the things that have come out of the woodwork are, people have actually left the country and not notified us. You've got people who are in the criminal justice system, etc. So as time passes, that data gets clearer and improved. What I've asked to see is that 3-month window from month 12 to month 15. So we get the vast majority done, I think it's something like 96% within the 2-year window. But what are we achieving within that first quarter of year 2? So we'll continue that focus in terms of the performance and the detail. I think the narrative behind those weights is going to be hugely important to CQC, because if you're saying that you're weighting well, you should be able to articulate that on a case-by-case basis.
Thank you. I am going to draw that to a close. Can I just say thank you so much to Matt and the team, and yeah, I feel very kind of reassured, but also I'm very comfortable and confident that we can, you know, have a good CQC process, and I can see how well the team are preparing and putting all the practical things to showcase, you know, what we do, you know, all of it really. So thank you so much, and the report is really clear, so thank you to Rebecca for putting it together on your behalf. So the recommendations are on page 108. It is recommended that the Adult Health and Social Care Policy Committee notes the progress in delivering upon the adult care strategy, Living the Life We Want to Live, endorses the strategy delivery programme and ambitions for the future, notes the performance update and areas for prioritization and focus, notes our approach towards reviewing early help and prevention, notes the preparation for the CQC assessment, which will take place before the end of 2025, and notes the continuing review and activity in relation to co-production, engagement and market sustainability. Are members happy to support those recommendations? Again, it's unanimous. Thank you. And that brings the meeting to a close. Yeah.
I should have noticed this earlier, but it's only because I was looking something up during the meeting that I've noticed. The Sheffield Directory website currently says undergoing maintenance, and some features might be unavailable while they're being worked on. Just wondered if we knew anything about that and how long that maintenance work might last.
I'll look into it today and get you a formal response.
Thank you.
It was on my list of things to ask, because that was something we worked really hard in terms of information sharing. So it's one thing that we need to sort out again.
Also, if we're working on information and advice, it's pretty important that system's operational. Yeah, thank you.
So our next meeting is on Wednesday the 17th of September at 2 p.m. So it's in the afternoon, just different from today. Okay, thank you very much.